now what is sort of the next advancement in incretin-based therapy, and these are the so-called unimolecular multi-agonists. So in this case, the one that's recently been approved is tirzepatide. And tirzepatide is a multifunctional peptide. Its structure is based on the structure of the second incretin hormone, glucose-dependent insulinotropic polypeptide, so GIP, and it's modified, though, to bind to both GIP and GLP-1 receptors. Importantly, it's got a C20 fatty diacid moiety, which binds to albumin, increasing its half-life. So it has a half-life of about 5 days, and this enables once-weekly dosing. And one of its key pharmacodynamic effects is enhancing the incretin effect. So enhancing glucose-stimulated insulin secretion, it enhances first and second phase insulin secretion, and it's also been shown to reduce glucagon levels, both in a glucose-dependent manner. And studies in patients or subjects with various degrees of renal impairment have shown that even in patients with end-stage renal disease, there's no difference in the pharmacokinetics compared to patients with normal renal function. So if you look at the label, there's no dose adjustment that's needed for EGFR, for example, and there's no lower limit of EGFR at which it cannot be used, although we clearly always need to be more careful with patients with chronic kidney disease. So it is a single molecule that possesses activity at two pharmacologic targets, the GIP and the GLP-1 receptor. And if we look at the mechanism of action, GIP and GLP-1 receptors are found on some tissues sort of commonly, if you will. So for example, in the central nervous system, there are GIP and GLP-1 receptors in areas of the brain that are very important in energy regulation. So in food intake and appetite and satiety, and also energy expenditure. At the level of the islet of the pancreas, in the pancreatic beta cells, GIP and GLP-1 as incretins increase glucose-dependent insulin secretion. Interestingly, GLP-1 reduces glucagon secretion and GIP increases glucagon secretion in a glucose-dependent manner, but tirzepatide actually reduces glucagon concentrations. But there's some tissues such as adipocytes that only have GIP receptors, and GLP-1 and not GIP delay gastric emptying. So some of the mechanisms are additive or synergistic and others are complementary, but the two together, you'll see, have quite impressive pharmacodynamic effects.